Hi, everybody, and welcome to the December edition of the Research Roundtable. This has been a highly anticipated event because the topic is of such importance to our audience, which is comprised of both clinicians and patients. I'm Brenda Viola for Lympha Press. I am joined by our anchor, Karen Ashforth. Our other anchor, Dr. Karen Herbst, is out of the country right now, but she was able, boy, Dr. Herbst's Rolodex, pretty amazing. We have Dr. Leopoldo Cobos Salinas with us, who is an expert in the field of GLP-1 and obesity. He's board certified in endocrinology and internal medicine and diplomate of the American Board of Obesity Medicine. So wonderful to have you here. I'm going to say Dr. Cobos for short, but we want to honor your mother and say Salinas as well.
Thank you. Thank you. Yes, it's Cobos Salinas. Salinas for my mom's name, Cobos for my dad's name. And thank you for the invitation. I'm glad to be here.
We
Sorry, my voice is
appreciate
might be a little bit raspy, but hopefully I could be understood.
We hear you beautifully. And we also want our participants, those who have logged on, let us know that you're here. Let us know where you're from. We know that this is being recorded so you can watch the replay, and we're here to answer your questions. So feel free to put your questions in the Q&A. I see Patty Cornute from Saratoga Springs. She is one of our top lipedema influencers in the United States. She runs a group called Lipedema Fitness. She had the good fortune, and she's been very open about this, to be able to be approved to have the medicine, and then her insurance changed their mind. And there's so many mixed emotions about this particular drug and how it can be used to help. But first, as a baseline, what are GLP-1s?
So GLP-1 agonists are a class of medications that were initially brought to treat type 2 diabetes. As type 2 diabetes is a self-induced condition where we literally overwhelm our body's ability to control our own sugar with our own insulin. So the way GLP-1 agonists worked in this scenario is in two ways. One is, as the name says, glucagon-like peptide 1 agonist, which is agonist means that it makes something work more than what it is. It already does. So these medications, once you start eating from the diabetes sugar part, it increases your own insulin production to sort of cover meals a little bit better. So some patients may actually see that when they're on these medications, the sugars before eating are actually higher than what they are after eating because of the effect this has. So they started to notice that these medications really attack the underlying issue in type 2 diabetes, which is the lifestyle. And they noted to be so good for appetite suppression, weight loss, then they started now studying for weight loss. And GLP-1 agonist, the main one is semaglutide, the one that got more attention. Now there's terzepatide, but basically people, when they, from the appetite point of view, obesity point of view, they feel fuller, faster, and longer once they are on these medications. Some of them have even mentioned that their binge eating episodes start going away. So it tends to act also on their willpower to say no to certain medications from that point, from the diabetes and obesity point of view.
So, full disclosure,
Yeah.
2 months ago, I started on Zepbound. I have been obese my entire life. I have never been able to break through a certain plateau. And this is not about me, but you will see me nodding a lot because for the first time in my adult life, I am able to walk past a tempting dish. I am not craving food all day long. I am able to control my appetite. And
Yes.
I consider the lack of chatter in my head an absolute miracle.
The way you're describing is the way I describe it to my patients, because when what you exactly mentioned is what I try to say, is you're never gonna change whatever's out there. You're never gonna be able to control what is offered to you, what you see, what is in your break room, in your school, with your coworkers, a party, all that. but you can control how you respond to it. So the way I try to explain is, before being on these medications in regards to the suppressing the anxiety to eat, it's like you have the little devil and the angel, right? You have both of them. That devil ends up saying, it's only a little thing, eat it. But with these, it's like it goes away, and you feel so much in power, so much in control, that there's no issue with you saying no. You could see things, food that before would just make you crave and want it, and now it's like, yeah, no, no thanks.
It's like I can flick it off of my shoulder like I never could before. Now, I will also say my insurance did not approve it, and I have had to scurry and rearrange my finances because I'm paying out of pocket for it. But because I have health issues in my family's line, and I have to watch this weight issue and my cholesterol and all these things, my doctor said, look, if you're willing to pay out of pocket, do it. So many people out there are struggling. They need this medication and they simply cannot afford it. And I understand and I empathize. Why outside of the United States is it so affordable?
Well, and just to add on that, they just increased the price this last year of that medication. So it actually, the CEO of the company that makes the main one, semaglutide, was actually interviewed by the Senate. And they asked him that same question. They put a chart where they showed that in the US it's $800,000, and in Europe it's 90, 60, $30. And he basically blamed it on the insurances. That he said that the price in the US is set by the people that are gonna pay for that. So that's a big issue. Like in medical school, they teach you what to use, and that's it. For this condition, you use this. But once you go out there real life, it all depends on the insurance. So the insurance sort of guides it. Now, the issue with even with the ones that are being approved, like Zepbound, Wegovy, they're used. That you have to have certain criteria, let's say BMI above 30 or BMI above 27 with obesity rate conditions. However, once you go down to the weight, which is the intention of the medication, let's say now your BMI is 26, you no longer meet criteria to be on it. So that's the other thing, that the continuation of it is what gets people, because it's when someone's taking blood pressure medications and you get to a certain medication regimen, their blood pressure is at goal. You don't get rid of those medications. It's the medication that's keeping it there. So what's happening is that they no longer have this help that they need for the whatever they need it for, and then they just start struggling and going back, and it's a yo-yo. Studies also have shown that in diabetes, at least from diabetes part, being uncontrolled and controlled, like these ups and downs are not good in regards to cardiovascular benefits. Even
We could probably, Karen and I could probably ask 20 follow-up questions on that response alone because there's so much in there, and we might go all around this topic, and we appreciate you just responding to what we delivered to you. We did have a question from the audience asking us to please address the latest information stating that eventually this medication stops working and the weight will creep back up.
Well, I have seen in patients that once they start on a certain dose of semaglutide, let's say 0.25 and then 0.5, and it helped for a certain amount of time, but then they start developing this sort of, of resistance to that dose, now requiring a higher dose. So yeah, some people do notice a difference or lack of efficacy as they've been on a certain dose. So once they reach, for example, 2 milligrams of semaglutide or 2.4, depending on which one, then that's when we tend to switch to terzepatide if they're able to do it. But yeah, they do tend to deal with this resistance. Now, the thing is, it's not the lack of the effect of the medication itself that leads to the weight gain. It's just that people do not feel the same appetite suppressing effects. So again, it's not the lack of the medication itself, it's the lack of the effect the medication gives. But in obesity, when we're using weight management, it all depends now from there for the patient to do what they need to do, because if not, then we're just accepting that we're depending on the medication to lose weight. Now with lymphedema is what I've seen is different.
Let's talk about that because a lot of the people in our audience have lymphedema and lipedema. And when you just said that, their ears perked up. So we're on the edge of our seats.
So it's, this medication is just based on BMI. So BMI, I think it's something that needs to be updated in regards to differentiate if it's obesity, metabolic obesity from overconsumption of calories, or even like football players have a BMI of 30 something, or if it's mass, or if it's mostly for lymphedema. So when these medications came out, I remember one even male patient mentioned to me that it did okay with the appetite, but he noticed he just got decongested, that his legs were swollen and now they weren't. So this little light bulb came up, and I was like, well, I wonder how would it work with patients with lipedema, lymphedema. So the patients that I had that time with lipedema, by the time they got to see me, some of them already had gastric bypass. Some already of them did multiple diets, supervised, multiple medications, and they didn't see the response that we usually are supposed to see. This is usually when doctors tend to say, yeah, you're not doing what you're supposed to do because everyone else gets better but you. So, but we have to remember, I mean, there's you don't treat everyone the same way. Everyone is different. So whenever someone doesn't respond to the conventional methods, then you start looking for, well, maybe it's a non-conventional thing. So going back, by the time these women come, appetite is no longer an issue. Food intake is no longer an issue because they've already improved their diet. They have already tried their best. They already had gastric bypass. So some of them tell me, I mean, the doctor told me that I need to eat less, but my stomach is this big. What does he expect? Like, and what gets them is what I'm eating does not match to how my body looks. So because of that, again, appetite is no longer an issue. So whenever we would give, whenever we start giving GLP-1 agonists to these patients, they actually didn't feel much appetite suppressing, because again, some of them, their stomach was this big, but they started feeling the decongesting. They started noticing that they were peeing a little bit more, that some of them even felt bloated and their bloating went away. And remember, these medications, the main side effect is gastrointestinal issues. So when I start hearing that their bloating went away, I'm like, okay, so how is this helping? Is this decreasing inflammation? Is it doing? Now, there are some studies that there's some GLP-1 at the level of the had to do with lymphatics, but I don't think that's been studied, or they've actually come to the conclusion of how GLP-1 helps. But again, the other thing is the way that I know it's helping purely with decongestion and not necessarily from the appetite point of view, is that, like in this question, whenever you're at a certain dose and you could keep that dose, but the appetite suppressant effects are no longer there, these women, they are on these medications. They usually do well with lower doses. Again, no appetite suppression issues, but the moment they stop it, they can keep doing everything the same. They start accumulating the fluid. So that's how I started to notice that was of helping the get rid of fluid, because they would keep everything the same except the GLP-1 agonist, and they would sell. Sort of like if you're on a medication for binge eating disorder and you stop it and the binge eating comes back and everything else stayed the same, then this is what they saw. Now, of course, the best benefit, the best decongestion came with people that continued doing their conservative measures. It's like I explained in lymphedema. Unfortunately, we have to help our lymphatic system or venous system. We have to support it, hence supportive measures. And not doing those measures while on these medications is like a diabetic type 2 that is on medications but doesn't change their life. So it has to be synergistic. They have to help each other. but I don't know if that answered your question.
Oh, it does. And we also understand that there still remains a lot to be learned about
Yes.
this. This is why we call it the Research Roundtable, because we're talking about the current research, understanding that still more needs to happen. But many of our audience members are typing in chat. It wasn't about obesity. It wasn't about the weight loss. It was about the inflammation relief they got from being on the drug. And my friend Patty, the minute her insurance denied it and she had to go off, she had an inflammation
Yeah.
surge.
No, and I agree with all the comments that it's we're not, and this is what I try to clarify when we presented a poster in Obesity Week 2023 in Dallas, and a poster that talked about the effects of semaglutide on obesity from lipedema. And there I explained that the weight loss, the decreased circumference in limbs was not because of appetite suppression of the conventional method to lose weight, is because of decongestion, because women get tired of feeling tired and feeling heavy. So now that they start having this new anti-inflammatory, when you're no longer in inflammation, your brain fogness starts going away. Because I mean, chronic inflammation, your body's just in stress all the time. I mean, stress is dealing with something actively instead of, well, like not being inflamed. So as if they already did the mini study where they check inflammatory markers before and after being on GLP-1 agonist and the same, then I mean that's 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 reassuring that it helps in that. I've had patients, they even said joint aches started to go away, but I have a suspicion it's from the same decongestion.
Yeah.
But yeah, I agree. It's and we're actually doing a study with the help of a Lipedema Foundation, where we're wanting to use a GLP-1 agonist, particularly semaglutide, in a clinical trial with women with lipedema, lymphedema, to prove that at least it's something to look at, so that we can start having medications that are for lipedema patients, because there's no FDA-approved medications right now, but we're making some noise. So hopefully,
We love the noise. And I have a bunch of patients that would probably be clamoring to sign up for that study. We need more studies. And Dr. Herbst actually wrote out some really great questions specifically to lipedema, but I want to get to some audience questions first. And I realize that we haven't even let you get a word in edgewise, Karen Ashforth. So feel free to jump in. Any comments at this point, Karen?
Well, I would say that I am certainly not an expert, but I've had a number of patients who've been on different forms of GLP-1 agonist medication and have noticed exactly what Dr. Cobos Salinas is relating, that there are lower inflammatory symptoms, and along with the complete decongestive therapy program, they are better able to control their lymphedema and lipedema symptoms. So I'm a big fan. And I'm actually very excited for tonight because I'm learning so much. I'm taking big notes. And I think that this is something that even though in the lymphedema, lipedema world, it's off-label use, I think it has an awful lot of promise for our patients. So that's where I stand.
So let's go to some questions here. We have a clinician, Linda Ann Kahn, who writes, she has a lipedema patient who experienced bad side effects initially. She has lost 30 pounds. She's taking 2.5, which is the introductory dosage. Her insurance is now saying that she needs to go up to the 5 milligrams, but she doesn't want to do it because she's having really bad side effects. They will not give her the medicine. What can she do? Now she's eating more. She's put back on 6 pounds. And, you know, is there any leverage with the insurances, with the medical profession to say, look, I'm seeing good results at 2.5. Can I just stay there?
well, I've run into the same issues, and I agree. I mean, the side effects tend to be also dose dependent. So some may tolerate 5, but not 7.5, and as in this case, 2.5 and 5. So I think it goes back to the indication. I think manufacturer established that 2.5 is the introductory dose and 5 may be the lowest dose. So they wouldn't want people to stay in 2.5. But I've had patients in that scenario, and there's 3 that I can remember. One of them just flat out said no. And remember, this is a doctor that is seeing the chart, the medication, all that, and just decides not to do it. But 2 other patients, I had to go into peer-to-peer. So it was denied, and then they mentioned that, and then I appealed it, saying that 5 milligrams is cannot be tolerated, and then they kept it at 2.5. But again, it's rare, and it all can come back to the FDA approved recommendation as far as the doses, where 2.5 is introduction. Now, the type of medication of GLP-1 agonist also has to do a lot, because the mode of the delivery is crucial. For example, semaglutide, only the diabetes one, Ozempic, the pen, you have 0.5, 1, and 2 milligrams. So even if you do the 2 milligram pen, you could still adjust to 0.25 or 0.5. So if they approve that 2.5, but they won't budge going to 5, then you could change it to the semaglutide. But again, only the Ozempic, because you could base it off of clicks to give lesser doses. But if it's the weight loss, the Wegovy, it's already in pre-filled pens. So my recommendation was to, I mean, it's a lot more time, but it's do a peer-to-peer, talking to the doctor that denied, saying like, hey, I'm not going to torture my patient with 5 milligrams. She can tolerate 2.5. But if not, then it will be switched to the other one. But again, it all depends if it was prescribed for weight or diabetes, or if it's self-pay, then, I mean, you get more bang for your buck if you buy the 2 milligrams and use lower doses. I don't know if I should be saying this.
Well, I want you to say whatever, because, we're not gonna, this is emerging, and you are on the cutting edge of this field, and my ears are definitely perked up. I just completed 5 milligrams, and I'm like, it's really working. Do I need to go up? Because I don't really think I need to. And my doctor said, yeah, you need to go up to 7.
No, what I tell patients is the doctor does not choose for you. The doctors give you the options, and according to what we tell you, then you choose, because you're the patient. So if I hear you being comfortable at 5, keep it at 5. You're the boss.
Did you hear that, everybody? You're the boss. And this is really good information.
That's what a lot of doctors forget.
This is so good to equip the audience with knowledge, so that when they can speak intelligently about this. Rhonda Wilkie is in the audience, and she has said she's read that Ozempic will be able to break up and burn lipedema fat. Will any brand of semaglutide also work? And is that true?
Well, I haven't seen research that have looked into before and after with biopsies, but patients, well, with lipedema historically is that you get to a point where you no longer lose fat, right? So that's sort of where they stay stagnant. Now, the patients that I have seen that are with GLP-1 agonists, again, with conservative approaches and sometimes with other medications, which sympathomedics, which help also further vasoconstriction and lymphatic pumping, they have lost leg circumference. And the study that we're doing, we're going to use bioimpedance and see if some of the fat went away. Now, there's no way to differentiate through bioimpedance lipedema fat, but if we get rid of fat overall and we see that the initial, let's say, thigh showed look certain way with certain lipedema fat there, and then we finished the study and we noticed it's less, then yeah, we could conclude that lipedema fat is going away. But unless we have the biopsy or something else that we prove before and after, we could. But what I base myself on is what the patients tell me, because let's say that it doesn't get rid of lipedema fat, but the patient said they noted a huge improvement, then it doesn't matter if the lipedema fat is really gone. They noted decreased in circumference, they noted improved in quality of life, activities of daily living, pain. And we could conclude that if that happens, then lipedema fat is going away. But that's the goal of this study, to see if it helps in that way. And I have my theory is that it does.
One of the Dr. Herbst's points in her notes to us in her absence, I wanted to raise this. She says she's seen amazing weight loss with women who have lipedema using the GLP-1s. She says there's often a nub of tissue left that feels very fibrotic. Some women have noticed more pain with weight loss if they have a lot of lumpy fibrotic tissue, especially in their buttocks and hips, and others notice pain reduction right away and a return of pain when they stop the GLP-1. Do you have any information about, and Karen Ashforth is an expert when it comes to fibrotic tissue, with regard to the use of GLP-1s and nubs of fibrotic tissue that remain?
Well, one the all of the patients that have up to now that have lymphedema, that are GLP-1 agonists have reported pain improvement. But again, this is not only GLP-1 agonists by itself. It's conservative approaches, keep doing what they're doing, keep a healthy diet, because although lipedema, yes, it's not brought up by overconsumption of calories, the bigger we are here, the more stress is going to give to the lower body. So if we gain weight here and then gain weight on the lower body, once this goes away, the lower body's going to stay. So what I've seen is the great majority, if not all of them, have reported pain improvement. My theory is that the women that do, and the question is, they had pain and then they started this and that pain went away, but they developed a new pain, or that same pain never went away and it just got worse. Because
It's like the pain that they had went away when they took it, and then as soon as they stopped taking it, the pain came right back.
well, and if that's the issue, then yeah, that reaffirms that the improvement is not the conventional the way it works. It's the decongestion, because that's what I hear. Once I stopped it, I feel heavier again. I feel brain fog again. I feel pain again. So the decongestion is what relieves the pain. Now, for the people that had initial pain, the took GLP-1 agonist, that pain relief, and if they develop a new type of pain, then my question is that another type of pain that's not from lipedema, lymphedema, that maybe was unmasked with a decongestion. Now, for the fibrotic tissue, what tends to happen, and this is what I hear with some patients, that they think they're developing new nodules, new fat, is that, so it's like whenever someone says that I have a six pack, it's just under the fat, right? So, or under the swelling. So whenever they're swollen, the leg may look a little bit lumpy, but once you get rid of that swelling, then you start seeing the actual nodules, and sometimes they feel like they're new ones, but you're just unmasking them. You're just drawing out the leg, where now you start feeling a little bit more, seeing a little bit more. So that's what I tend to see, and that's what I tend to tell patients when starting these medications. Sort of, this is what you may anticipate. You start thinking that you start to develop new ones. First of all, they're not going to develop right that fast. And second, they're already there. We're just noticing a little bit more because we're getting rid of that excess fluid. But them developing new pain, different from what they had, my suspicion, or the thing to look at, is if it's another type of pain, because then you have to look at pain like through the other part and not necessarily lipedema pain.
When you said this unmasking, I saw you nodding, Karen. That makes perfect sense, doesn't it?
Everything that Dr. Cobos Salinas is saying, I tell my patients all the time, whether it's losing fat, losing fluid, it's like having a lake with rocks underneath. And if you drain the lake, all of a sudden you see the rocks. And if there are these layers of, either swelling or different types of tissue, it pads the body. And I have a lot of women with lipedema, in particular with nodules, that are so painful that sometimes they can't even sleep on their side. And so that's kind of it's a difficult side effect of decongestion. And that's where we really get in there with our antifibrotic techniques and work on those. To answer the original question about the tags of tissue that are remaining, I think that, Dr. Cobos Salinas is right on that that's got to be what's going on, is that there's fibrotic tissue that's been there all along that's being revealed.
Wow. So we are getting lots more questions, and even they're in the chat. So if you have questions, stick them in the Q&A so I don't miss them. There is this issue of plateauing. And one of our clinicians said she had a patient that plateaued, so the doctor switched her to a different medication, I guess, to see if it would dislodge from that plateau. Do you have any thoughts about plateauing or people who may just simply be resistant to GLP-1s?
Yes, both. I've had patients that tell me that they get hungrier once starting semaglutide, and then we switch to terzepatide, and voila, they do a lot better, and vice versa. So, and again, when they do these studies for these medications, it's not 100% of the people found benefits. The majority of people found benefit, but you have some outliers that no one ever talks about. So, that's the importance about treating the patient and treating numbers, or just like following what the books say, because yeah, it's gonna seem like the patient is not being truthful when they tell you, yeah, I'm hungrier with Ozempic appetite, but if you do the switch, now you're gonna see that they do better. So I tend to do the switch as long as insurance approves, once they reach max dose of whatever we started first. And yeah, once they reach a plateau, by that time, typically they've already also reached a plateau in the appetite suppressant effects. And that's when we switch. And if they were in semaglutide, then we switch to terzepatide. With terzepatide, you have to start from the beginning. Now, that's for the appetite suppressions. Wait, from the lymphedema lipedema point of view, they tend to stay on that same dose. And I have rarely had the need to switch him, unless it's insurance purposes, or they ended up having to, like, have a patient that buys it in South America. There's a patient that I live in the board Laredo, is boards know Laredo. So they sell it in Mexico. In Mexico, it's about 4,000 pesos, like 200-300 bucks. It's still significant, but it's way less. However, they're all running out of them because everyone is crossing over and buying them. So yeah, whenever they plateau, whenever they feel that it no longer is providing the same effect, then we tend to switch them. But I'm really careful in not increasing the dose too fast, because a lot of patients want to go up real fast, like if they are running out of time. And I tell them the faster you reach the higher doses, the less options we're gonna have in the future. But again, those plateaus I see more when it's has to do with appetite, which patient with lymphedema sometimes do need appetite suppression or binge control, because I mean they try, but they just tell them that they're not trying. So all of this just creates a like a feeling of, well, I guess I'm not doing what I'm supposed to do, and they are trying, but I mean, there's only a certain way you can reach. But yeah, I'm sorry, I went on a tangent, but yeah,
No,
I
we love your tangents. And what genes are important when it comes to
for
this? So Dr. Herbst
mm,
says, why do some people not respond to GLP-1 agonists? What genes are important?
um that's a good question. I'm not aware of why there were genes. Like, for example, they talked about this with metformin, which is diabetes drug, and some weight loss centers use it for as an initial therapy for weight loss. Lipedema patients have it using it as well. Some of them for the fibrosis. But there's some people that do not tolerate metformin at all. Some people get really bad side effects. Some people that does nothing. So it would be interesting if they could break down like each individual person that respond non-responded, like maybe their genome. But I'm not sure. I don't know which specific gene would be related to why they respond or not. Uh,
Gotcha. So here's a
I have the
very
same question.
Yeah, it's a good question. And, we love being on the radar of the Lipedema Foundation because they are really funding so much interesting research. So, we just stick a post-it note on that one. Sandra Willis is in our audience tonight, and she has a really interesting question. Is it possible that obesity is a malfunction of the lymphatic system, which is responsible for picking up fatty acids and vitamins? Maybe she's conjecturing here. Maybe people keep eating because they're trying to get vitamins. And if so, is there something about the GLP-1 that affects this nutritional uptake?
So, so again, the as far as GLP-1 agonist, the question is, how does it work from like the nutrition point of view, like the absorption, or
Yeah, I think she was trying to connect the dots between a condition like lymphedema and the obesity
yeah.
and nutrition, and maybe the GLP-1 helps build that bridge for nutrition.
Well, I think it helps in both, yeah, because although again, lipedema is not because we overate calories and then our body did not use them and had to store them in the bank, which is fat, which is stored energy. Um, when it comes to the point with lymphedema, so lymphedema, the lymphatic fluid has a fat component in it. So whenever, the way I try to explain it, whenever patients start getting lymphedema, if that lymphedema fluid does not move, does not uh, taken care of with compression stockings, MOD, cell massage, then it's the body is going to start sort of creating fibrotic tissue, and it starts converting into this lipedema fat. And compared to fat that we have because we overate, that's like metabolic fat, that's energy to be used for later use. This fat from lymphedema is inert fat. So it's not that the body put there that fat there to be used for later use. That is inert. So that's the reason why lipedema patients, doesn't matter if they fast, gastric bypass, everything, they're not going to lose that weight because that's not stored energy. The body did not put it there. The body tried to uh, uh, create a like a encapsulate in a way to speak, creating fibrotic tissue, and that is what started lipedema fat. So then with more lipedema, more lymphedema, it's not moved around, it's not and the legs are not getting decongested. We're just going to have a cycle where we're going to get to the point where it's all lipedema fat and nothing is going to make it go away, but what they're doing now is liposuction. So yes, she's right. BMI, the thing is, BMI is based on a calculation of height and weight. So like I said, a patient that is type 2 diabetic that overate and got to the point where they're really uncontrolled could be have a high BMI. Football player that's super healthy, but it's also can have a high BMI. A lipedema patient that takes care of their diet, metabolically they're healthy, can have high BMI. So by definition, they're all obese, and that's what I said initially, that has to be reclassified because you're telling me that they're all obese, but the three of them, one doesn't need treatment, the other two, the treatment has nothing to do with one or the other. And I think that's why there's still a lot of unawareness, even in the medical community, as to what lipedema is, because it all starts in med school. A lot of them is whatever was taught, that's the only thing that exists. And even if there's new things coming out, they won't look at it. And that's the main issue, that I honestly think that lipedema is not rare, it's rarely diagnosed. So that's the thing, that we're just not being aware of it. So we're like, yeah, it's rare, I never see it, but because I never detected.
That
but
is it. Oh, you're preaching to the choir. We
but
actually, yeah, go ahead.
oh, sorry, just to finish the nutrition part. So what I tend to advocate for patients, and this is what I write my letters when they're continuing surgery, is that yes, although lipedema fat is not metabolic fat where we overate and led to this issue, it gets to the point where they get so heavy, so congested, so depressed, so down, that they start overeating, and that overeating and that sedentarism eventually leads to bad nutrition, which eventually leads to diabetes. And now you have metabolic obesity plus lipedema, lymphedema, and I mean, it's just a never-ending cycle. I mean, this is the women that are in their 70s, maybe 80s. Their legs are huge, and they walk like hunched to the front with a huge walker, because they just let the disease run its course. And I mean, I'm sure they've seen a lot of doctors, and they've been asked what to do with it, but I mean, they a lot of them suffer in silence.
Oh, and Lympha Press 5 years ago really began devoting time and energy to the study of lipedema and how to help lipedema patients. You talk about the fluid that pools there and just needs to be moved out. So our compression therapy helps that aspect. And we've seen lipedema patients experience reduced inflammation and increased mobility, and it's so heartening. And we support patients every month. We have a roundtable discussion. We've built a community because you don't want to suffer alone. You want to rise up, not give up, but support each other. And we are really all about that. And
Make
that's
noise.
why we were into doing this topic tonight as well. Again, we have clinicians and patients on with us tonight. Let's talk about this muscle mass issue. We have some of our patients in the audience tonight that run triathlons, they are more physically active than I will ever be. And there are questions in the audience tonight about skeletal muscle, and does the GLP put you at risk for muscle loss?
So there's been some reports that yes, skeletal muscle goes down, but um, I believe it's from the weight loss itself, not from the actual medication. Because in some people, the appetite suppressant effects is so severe that I mean, they literally eat very, very little. Some of them even, like, doesn't matter if they have really bad side effects, if they throw up whatever they eat, they still take it. Now, in my opinion, that's it. I've seen it more in patients that go to the extremes and lose weight, but also patients that just rely on the medication for appetite suppression, but do not are not active, are not doing any type of exercise, because lipedema patients still need exercise, still need to have activity. Why? Because the veins, which are working with the lymphatic system, they try to catch up when the lymphatics don't work. If they don't have a pump like the arteries have a heart, right? So the heart pushes blood through the arteries, but then the veins bring back the blood to the heart, but the veins do not have a pump. You don't have a pump in your feet, so they require muscle contraction to move the venous fluid and lymphatic. That's why whenever women are going a long flight, when they get to the flight, they're swollen. Why? Because you were just there, you just let gravity do its thing. So exercise is huge, and thing is, whenever you start losing lipedema, metabolic fat, then your body starts looking for other forms of energy, and so it may start breaking down some muscle. But in my opinion, I don't think it's the Ozempic itself that is leading to the less skeletal muscle. It's the actual weight loss it has, maybe plus a little bit of too much caloric restriction, and likely a lack of resistant exercise, because like weight training. It doesn't have to be something huge, because if you do cardio, I mean, you're not really going to build muscle. But again, that's in my opinion. So I don't think it's itself the GLP-1s. It's the effect it has, because people that do gastric bypass or just lose weight for other methods may also have lesser skeletal muscle.
So it's not a fait accompli that you will lose muscle mass if you incorporate movement. Just like Patty Cornude of Lipedema Fitness does. Her mantra is all or something.
Yeah.
Move.
You have to demand your muscle to do its thing. If you don't demand from your muscle is going to be like, hey, you don't need me, so I'm just going to start coming down. So no, you have to push it. You have to push it. The same thing with your brain. Like if people, as they grow, if they stop doing crossword puzzles or working, their brain is going to start shutting down because you're not using it. So if you don't use it, you lose it, and that includes muscle mass.
Okay, I can't believe we only have 15 minutes left. I'm going to stop for a moment. Karen Ashforth, do you have anything you want to add at this juncture? Because we have a boatload of questions in the Q&A right now.
Let's keep it rolling.
All right, we're going to roll. Here's two issues that continually keep coming up. What about compounds?
All right, so well, first we have to look at why these medications are generic, right? So whenever a company does their own product, like they own that compound, that chemical, so that's what they call the patent. But the FDA has this rule, I guess, that if you don't have enough of your product in the pharmacies, then you sort of have to give out the recipe. So that's why, even though semaglutide, Ozempic, Wegovy is relatively new, now they started doing generics because of the lack of Ozempic that was going on. The same thing happened with terzepatide, Mounjaro, but now they restocked. So now they got it off of the short list. So semaglutide is the one that's out there right now. Now, I can't guarantee that with compounds, they're getting the same thing that they would get coming from the actual company. Why? Because at the end, their business is trying to make a profit. So the way they do it is they buy bulk, or they do their own injections, and sometimes they put, and this is by no means talking bad about others, just explaining, answering the question. So they may add B12 or other vitamins. That way you'll not only get the GLP-1 agonist, but I mean, what I recommend when they ask me that is, if you take it, it's sort of at your own risk, because I can't assure that what you're taking is the same thing that I would recommend. But if you feel it's working, if you feel it's providing the same benefits, sometimes I give them a sample of the GLP-1 so they could try, see it works. If that's something that your pocket can afford, then I mean, you can continue it, but I don't tend to prescribe it, because I've seen different results. I've seen patients that do find the same benefit, but I've seen patients that even with the highest dose did not. And I think that's also depends on where you get it. Now, I'm not saying that, but it's important to have that in the back of your head, because there's some places that I've seen that charges like $200, $200 every 2 weeks. There's some that charge 400, and the doses are all different. So here in the border, the other option is people go across and they get the actual legit medication for about 2/3, half of the price. But they'll be lucky if they have them, because with any border town, medical tourism is huge. And I'm actually from a border town, from Piedras Negras, Coahuila, border town, Tijuana Pass. So a bunch of people from the US go and buy them over there. But the generics, my recommendation, I'm sorry, the compound, again, I don't recommend it sort of at your own risk, but if you, it helps your pocket, it helps you in what you need it for, it doesn't give you side effects. I mean, it's go for it.
And you've been clear throughout this whole program. It's not one size fits all. Everybody has a different body and a
Exactly.
different reaction.
Mhm.
But I thank you for, that caution and yet also the exhortation that if it's more affordable and something you might want to try. Here's the other question that keeps coming up. Microdosing. Do you have any thoughts on microdosing as a benefit to lymphatic disorders, presumably inflammation reduction?
So going back to dosing it based on the pen. So again, the only one that could be adjusted for microdosing would be the semaglutide, the Ozempic, because let's say with the 0.5 milligram dose, that pen has 0.25 and 0.5. But if you base it on the amount of clicks, even with the higher dose of 1 or 2, you, I have prescribed patients or I've recommended patients to do lower dose. For example, some may take half of 0.25, which is 0.125, and they just do it based on the clicks. Some base it off of counting the clicks. So it's even less than that. And again, this is something that the patient is going to tell you if they tolerate or not.
Mhm.
Some patients are a little bit iffy starting these medications because they've heard some studies that it messes with your gastrointestinal system. Um, but just to clear that out, there's a study that came out that said that GLP-1 agonists had 4 times risk of gastrointestinal issues, pancreatitis, all that, compared to other weight loss medications. But the study that they did, it's like comparing apples to oranges. Those weight loss medications, they were both weight loss, but they work very different. But the side effects, the serious side effects in the 100% of the population that take these is less than 1%. So the microdosing helps. One, if the patient is iffy on starting something, and I never want to sort of persuade someone to take anything, because no, I mean, it's you never force anyone to take anything. But when I know something helps and something has been proving beneficial and I know that may help you, I mean, I may push a little bit and to get to a point where we're both comfortable. But at the end, I've had a couple of lipedema patients that said that they don't want to start anything even after that. So yeah, microdosing you could do, but unless the compounding pharmacy gives you microdosing, which I doubt, because then that means that you'll buy less from them. Then the GLP-1 agonist, the Ozempic, is the one that you could do microdose. But I do tend to recommend, because again, everyone's different. I have a patient that's doing very well on 5 clicks of Ozempic, which is like 0.00 something.
Okay, so listen to your body. With regard to lean body mass,
Hmm.
Linda Ann Kahn says that she has read that lean body mass is lost as well with GLP. And if you put the weight back on, it's not lean body mass that returns. Is that an accurate statement?
Well, it all comes back to muscle mass. So I assume that it's lean muscle, so muscle mass. So yeah, it comes down, and because of what we talked about. And yes, if you regain the weight, unless you're working out and developing new muscle, then that muscle is going to stay there, and that could actually be worse. Why? Because you can now feel weaker. Why? Because whenever you carry weight, your muscles compensate for that, right? So you have 20, 30 extra pounds of fluid, of fat, your body's gonna do a little bit more muscle, so you could pick up your leg, move it, and all that. So whenever they lose the weight, if they lose muscle mass and then regain the weight, now you have a smaller muscle with a bigger leg. So now they weaker, they're drag more, they feel more congested, and they feel worse than what they already have. And the rebound seems to come with a vengeance. But
Mm.
again, it has to do with, again, exercise activity plays a huge role. They did a study where they looked at the people that lost the weight, what made them keep it down, and it was exercise activity.
Wow.
So for lymphedema, that also applies to help decongestion.
Do lipedema patients inherently have low skeletal muscle even when they are active? Question from the audience, Che Shavrik. Thank you for the question, Che.
So I I uh, I think so, but the reason I think so, because whenever we see lipedema patient and they do a functional assessment test or functional capacity, they tend to be weaker. Their strength is weaker. Things that they do now. Could it be that it's a weak muscle or a muscle that's not strong for the weight that the leg is having? That's a question, because it may be that they don't necessarily have less muscle, but they have too much fat, too much congestion for that muscle. And the thing is that with lymphedema, the weight gain, weight loss tends to happen something a couple of days, weeks. So it's not a constant weight gain where your bodies are able to adapt into it. So I think that it's also that it's too much congestion for the body too. It's part of the heaviness, so to speak.
Monica Shirk had a question about decongestion. Which medicine helps decongestion best with the lowest side effects? Or is that a case by case basis and how your body tends to respond?
Yes, that's on a case by case, because I mean I can tell you that again GLP-1 has worked, but there's other medications that have helped. For example, Dr. Herbst did a study where she looked at patients with lipedema, which have been on medications called sympathomedics like phentermine, Vyvanse, dextroamphetamine. Those are the medications that I have mentioned a while back, that they also help with the lymphatic pumping, constriction. So when we add those medications to people that are already taking the GLP-1 agonists, it's like a synergistic effect. They feel a lot more benefit. So I don't know if I answered the question.
Well, you did.
Uh,
And I see us at the 3-minute mark, and everybody wants to know how to get in touch with you. Dr. Cobos Salinas, you've been amazing tonight. And I want to ask you for some broad closing remarks, but how can people get in touch with you? And are you seeing patients?
so yes, I have my endocrinology practice in Laredo, which is South Texas. So it's I-35, 2 hours South San Antonio. It's where actually I-35 starts. So I see general endocrinology, but I also see lipedema patients. Typically, I like to see them in person because I take my time. I explain to them everything in detail, what's going on, sort of what we talked about right now, but in person. And then physical exam and history is important to diagnose it, make sure that we're not missing anything else. Sometimes if it hasn't been done in the past, as a hormone doctor, I make sure that there's no hormonal issues that need to be taken care of first before we say it's lymphedema. But my practice is called Cobos Endocrinology, and it's 6999 McPherson Street, Suite 108 in Laredo, Texas. I also am faculty with internal medicine residency program at Laredo. So work with the University of Cardinal Works School of Medicine. So I train these medical students in internal medicine residency. Everyone that graduates from this residency program knows about lipedema. So I tell them, even if you're not going to treat it, you need to be aware of it, right? Because you need to know when it's not your conventional obesity. So I've had some graduate already, and I've felt good when I start seeing referrals for lipedema, because now they're diagnosing, now they're detecting it, they're referring. Also, since I work for the residency program, the other attending physicians that run obesity clinics and so forth have obesity clinics referring me lipedema patients, and which is huge because they're aware that, yeah, this is not your usual obesity. So the study that I'm doing, I'm involving students and residents again, so that there's awareness into this. Yeah, I'm glad
Well,
to
there's
have
a
this.
heartfelt thank you. We need more
Mm.
medical professionals like you that care about this underdiagnosed condition that affects one, and I think it's 11 women. And we thank you for taking the lead. Any closing remarks? First, I'll go to you, Karen, and then Dr. Cobos Salinas. Any closing remarks for our audience?
I am just blown away. This is a remarkable evening with lots of really great information. And I think we've just hit the tip of the iceberg. I really think that there is a lot more that we can learn. And I'll pass it over to you, Dr. Cobos Salinas. Thank you so much for all of your education to us.
It's my pleasure, and thank you for the invitation. I think this type of webinars is very, very, very important, and for all the lipedema patients. I mean, yeah, sometimes you're not gonna run into the doctor that sort of listens to you, but like I tell a person, when you go to a restaurant, they don't give you the food that you want, or you don't like it, and look for another one, and because that if at the first time that doctor did not consider what you brought, because a lot of times it's like that. They self-diagnose themselves, they bring it to the doctor, and they're like, who's the doctor? Right? Who went to medics? So only you know your body more than anyone, more than any doctor. So yeah, if you don't find anyone that listens to you, look for another one. And if there's anything that we could do as far as Lipedema Foundation to start, because we're trying to build sort of a network to see who can see lipedema. For example, some of my co-fellows that also look at lipedema, some of them are in Wisconsin, some of them are on Florida, so they're aware of that. It's just that they don't get referrals because no one refers to them. So um, keep trying, and because what lipedema women have done is build the future for the lipedema patients of the future, because you're building it now so that the future use don't have to struggle with this, and that's what we're here for. That's why we're going to do these studies and shine a light and yell and make sure people know about lipedema. It's already started to be put in the obesity medicine boards, and if there's any questions, any research things, topics that anyone has, I mean, you could shout out. My email is cobosendocrinology@gmail.com, like the name cobosendocrinology@gmail.com. So if there's any questions, just make sure put webinar patient, and I'll when I look at it, I'll answer back.
Fantastic. We like you so much. We want you to come back sometime.
Yeah, for sure. As long as you invite me.
We will invite you. You are amazing. Thank you for your time. Thank you, audience. You were on fire tonight. Your questions were insightful. Your chat was as well. Thank you for being a part of this community. The Research Roundtable works because of you. We want to answer your questions and let you know you are seen and heard, both patients and clinicians. We're here to support you at Lympha Press. And with that, you have a great night, everybody. Thanks for tuning in. Thank you, Dr. Cobos Salinas.
Thank you. Y'all have a good night.
Bye-bye.